So as Dr. Weissman said, I'm going to take the next half hour or so to give you a brief overview of things you can do in your office to care for kids with depression. I'll start with talking a little bit about why this is important. And I think most of you know this. Depression is a huge public health problem. It's one of the most common chronic illnesses of young people. Up to 8% of adolescents will meet criteria for depression, major depressive disorder at any given time. And about 1 in 5 kids will meet criteria at some point before they reach adulthood. This is a major concern because depression affects multiple areas of a child's life. Physically, these kids have sleep and appetite changes. They don't take care of themselves as well. They'll change their eating habits. Kids with chronic illness who become depressed may not take care of their diabetes or their CF or their asthma as well. This affects school performance. The concentration, focus, motivation issues that go along with depression can lead kids to not complete their homework. The sleep disturbances and motivation, they're falling asleep in class. Grades drop. It affects kids socially. They're not as interested in spending time with their friends or their family. They withdraw. They spend time in their room. They're crabby and irritable, so their friends and family are not particularly interested in spending time with them either. And it kind of disrupts relationships. And what we see with kids is as they become more isolated, more hopeless, more withdrawn, they can turn to more and more maladaptive ways of coping and interacting. So turning to substance use, turning to self-injurious behavior, turning to risky behaviors like sex or criminal activity as a way of managing emotions that they have. And as you can see and as you know, these issues aren't just social. This is a major threat to health and life for kids. Suicide is the 3rd leading cause of death in 15 to 24-year-olds. Suicide kills more adolescents than AIDS, cancer, diabetes, most of the illnesses that you treat in your office. And 90% of suicides are related to some type of mental illness, most commonly depression or substance use. So these are hugely disabling illnesses. So beyond the public health issues, why is this important to you as a practicing pediatrician? I don't need to tell you this, but these kids are in your office all the time. And I also don't need to tell you that access to specialty mental health care is difficult to get. There have been some studies about referrals to mental health care. In one study, less than half of the kids that were referred by their pediatrician for a mental health appointment even made it to 1 appointment in the following 6 months. But the grand majority of those kids wound up back in their pediatrician's office. Kids were more likely to actually make it to an appointment if the appointment was available within 3 weeks of the referral from their pediatrician, and if the pediatrician themselves or the parent made the appointment while they were sitting in the office, rather than the desk staff making the appointment or just handing the family some contact numbers. But even then, the number of kids actually making it was pretty uninspiring. There's lots of reasons these kids come back to your office. One of them is that you're wonderful. And parents trust you with their children's care. They want to see you. They know that you're the advocate and the go-to when parents have questions about their child's emotion or behavior or development. A couple of other reasons: kids with depression are more likely to have psychosomatic symptoms, especially younger ones, but adolescents too. You're going to get a lot of tummy aches and headaches and some of those other things going along with depression. And like I said earlier, depression is going to complicate management of chronic illnesses, so they may have more difficulty managing ongoing illnesses like diabetes or asthma. So this matters not just to me, but to you, because unfortunately, these kids never make it to my office, but they're in yours a lot. And so I'd like to give you a little bit of information about how to care for them. Now, we are working on trying to get more access for kids. The workforce issue is a huge one. If you divide that 8% or that 1 in 20 kids number into the number of people in the mental health workforce, we get about 2 hours per child per year that we can devote to kids who need access to us. So there just simply aren't enough people to meet the need. There's lots of people working on models to improve access, everything from some of the efforts toward having a wider variety of people seeing children's mental health issues, working on integrating care, and we'll talk about some of those models later, working on providing incentives for people to go into pediatric mental health. There's also different movements afoot using EMRs and other electronic techniques to help improve communication between the child's medical home and their mental health providers so that everybody's in the loop. And obviously stigma is a huge barrier in getting our families over that that hump into mental health care, and there's lots of attempts to do that. But these are long-term efforts, and right now these kids are still here and they're still sick. We'll talk a little bit just quickly about diagnosis of depression. People use depression colloquially as a term to describe a sad mood. And that's one component of it, but major depressive disorder or some of the other depressive illnesses incorporate more than just mood. There are mood symptoms. These kids can be down, they can be sad. Kids with major depressive disorder are also irritable, and often you'll hear from the parents, and especially, it seems like especially in boys for whom sadness is not a term we're allowed to use because we're a little too macho for that, that they're crabby or they're blah. And an adolescent, if you ask them how they're feeling or if they've been feeling sad, they might shrug and they just say, no, I'm not feeling anything. And that can go along with depression. They also have difficulty getting excited or getting happy or enjoying the things that they used to. I was just seeing a child yesterday whose parents told me we knew something was wrong when he didn't want to play with his Xbox at Christmas. They have a harder time enjoying those activities. The cognitive symptoms are one of the main areas that we get disability and dysfunction in life. So kids are having difficulty keeping their mind on things. They have difficulty making decisions. They can get anxious. We get more test anxiety. We get more difficulty processing those questions. And then we also get changes in actually the content of their thoughts. So they become very self-deprecating. They blame themselves for things. They have a hard time seeing that things could get better. They get very hopeless. And then we see the somatic changes. We talked about, headaches and tummy aches, especially in our younger kids. Sleep changes, and, the classic melancholic major depressive symptom is the early morning awakenings, but we really see in depressed kids disruptions throughout the sleep cycle. Difficulty falling asleep, they have difficulty staying asleep. Some of these kids, if you actually get a sleep history from them, they're spending a lot of time in bed, but not much of it asleep. So you'll hear from parents, gosh, they're in bed all the time. You'll hear from the child, I'm hardly sleeping at all. And it's a combination of the two. You also get the restlessness. Kids can get this inability to sit still. They need to pace. They need to do other things, or just being completely unmoving, and then again the vague somatic complaints. Major depressive disorder requires symptoms of either anhedonia or mood changes, depressed or irritable, plus a constellation of these other symptoms lasting up at least 2 weeks, most of the day, nearly every day. Dysthymic disorder is a more mild form that requires some of these symptoms more than half the days for at least a year in kids. And these are kind of our two main depressive syndromes. I want to spend the bulk of the time talking to you about what helps. And there's a combination of meds and psychotherapy. We'll talk about that. And then I want to introduce you to some of these models that people are using to improve access to evidence-based treatments for kids. So TADS was a big NIMH-funded study that was done in 2000 to 2003. And this is where we get a large piece of our data about what's helpful. You'll see our numbers here. This was a study of 439 adolescents aged 12 to 17. These were kids who were not in active treatment for depression at the time they enrolled, and it was a 12-week study where they took kids, divided them, randomized them into groups of either placebo, fluoxetine, Prozac, CBT, which is one of our evidence-based therapies, or a combination of CBT and fluoxetine. After 12 weeks, the kids who were unimproved on placebo could choose to get into one of the other arms. So the longitudinal data about improvement over 36 weeks in follow-up with these kids is only for the 3 active treatment arms because they could choose at 12 to go into one of those arms. What you can see as you look here is that all 4 groups got somewhat better. But there was a definite difference in remission rates. After 12 weeks, combination treatment was clearly the front runner, with fluoxetine behind combination treatment. CBT alone, about half of the kids got better, and then no treatment, the placebo arm, was 35% of kids were in remission. Now, over the course of the next 24 weeks, those other arms of the study kind of caught up to combo treatment, and by the end of 36 weeks, 80–85% of the kids were in remission. As they tracked suicidal thinking or suicidality, what they found is it went down in all groups, but those taking fluoxetine alone had a higher instance of suicidal thoughts, about 15%, compared with those in the CBT and combination treatment arms, which was 6 to 8%. And that difference seemed to be most prominent in the early phases of the study. There were no actual suicides in the group. So the conclusions we took from TADS were that kids seemed to get better with combination treatment. CBT alone did help, especially over time, and in combination with fluoxetine seemed to help mitigate that risk for suicide early on. Tordia was another large NIMH-funded study. This was a study of adolescents, and these were kids 12 to 18 who'd had a previous trial of an SSRI and didn't respond to it. So they're asking, if they don't respond to the first step, what's the next step to take? And there were two pieces that they randomized them for. One was to switch medicines to either another SSRI or to Venlafaxine, which is an SNRI, so a medicine with a little bit different mechanism of action. And then they also randomized them to either add on CBT or not add on CBT. This chart is small print and it's a little difficult to read, but basically what they found was that adding CBT to a med switch was better than the med switch alone. There wasn't any difference really in response rate between switching to an SSRI versus switching to Venlafaxine, but what they found in looking at suicidality data was that the kids who did the switch to Venlafaxine had more suicidal ideation and self-injurious behavior than kids who switched to an SSRI. So the story from these two big studies, and I think the take-home point for you in the office, is that SSRIs are safe and effective first-line treatment, and that kids seem to do better when we add CBT, both from a mood perspective and from a suicidality and safety perspective. So let's talk a little bit about these two treatments. We'll start with SSRIs. These are the selective serotonin reuptake inhibitors. Obviously, they increase the amount of serotonin available in the synaptic cleft. Now, after it does that, we really don't understand yet what happens and why that's effective for mood. The chemical imbalance hypothesis that was floated around a long time ago is something that's kind of been rejected, in part because we really see that these take weeks to help, to have downstream effect on mood, rather than the immediate increase in serotonin in the synaptic cleft. We're beginning to trace and understand some of the neural circuits that underlie affect regulation, anxiety, pleasure and reward systems, and we think that there's probably a downstream effect of meds on these neural circuits and their effect, but we haven't traced that out entirely. But all of the SSRIs seem to work in the same way, and so there's some general principles when you're dealing with these. We generally, in the outpatient setting, will start at about half of our initial target dose, have a child on that for 4 to 7 days to make sure that they tolerate it before stepping up. If they're having any of these common side effects like GI distress, headaches, some kids get a little increased anxiety, and then sexual problems are common and something you'll want to warn your adolescents about. Sometimes we'll slow down the titration, especially for the GI distress and the headaches. Again, it's really important to counsel kids and families that it takes 4 to 6 weeks before they're going to get a full benefit from a dose. We often hear kids and families saying, yeah, I took that medicine, but I took it for like a week, I didn't see anything different, so I just stopped taking it. And that anticipatory guidance with a family of saying, you know what, we don't anticipate this to help. Initially, it's one of these things that you have to take every day for a while for you to get better. And if it's not helping after a couple of weeks, that doesn't mean it's not going to help. That would be exactly what we expect. And it seems like that kind of helps kids with the compliance and helps families too. Some of the things we worry about are the akathisia, this restless sense of not being able to sit down, needing to move, kind of a creepy crawly sense. And part of why we worry about that is that seems to be a risk factor for suicidal actions. Suicidality itself, it can be a side effect of the medications. We'll talk about that in a minute. And then triggering mania. So when we're consenting parents and talking to kids, we talk about these particular things as being a reason to pick up the phone and call right away and to talk over the phone about what to do. Serotonin syndrome is our big bad scary thing that can happen. This is, mental status changes, hyperreflexia, hyperthermia. It's activation of your endocrine system, and you get that. That's something that requires an ER visit if you're worried about that. We usually treat it with benzos. We can treat it with a few different things, but it can progress to kind of circulatory collapse. So that's something we warn parents about. You know, if they seem jumpy, if they're not making any sense, those kinds of things, call me right away or bring them to an ER. So I've put the SSRIs in a chart here talking about FDA indications and specific doses for you to have this available. We usually choose a med to start with based on what we know about somebody's physiology, which generally means what we know about what some close blood relatives have responded to. So if a sibling or a parent has responded well to a particular SSRI, often we'll start with that. If nobody in the family has had a positive response or has really had any experience with an SSRI, we often go based on the FDA approval, and then sometimes cost, side effects, those other things. Now again, the side effects tend to be similar, but paroxetine itself has actually received an FDA warning about a higher risk for suicidality compared with the other SSRIs. So there's specific labeling about that, and most people consider this not to be a first-line treatment for depression anymore. The other SSRIs, fluoxetine has indications for depression in age 8 and above. Escitalopram, Lexapro is indicated for adolescents. And then sertraline, Zoloft, and fluvoxamine, which was marketed under Luvox but isn't available as Luvox anymore, are both indicated for OCD but not for depression. But again, we think these all work similarly. Citalopram is just the racemic mixture of escitalopram and the inactive R enantiomer. Fluoxetine and citalopram all of them but escitalopram are available as generics. Fluoxetine and citalopram are on the $4 generics list at some of the local pharmacies like Target and Walmart. So if you have a family for whom financial considerations are an issue, they can be a good first place to start. Fluoxetine is also a good choice in adolescents because of its long half-life. There's an active metabolite of fluoxetine that has a half-life of 3 days. And so if kids are forgetful about doses or tend to have difficulty taking it close to the same time every day, fluoxetine can be a good choice. Paroxetine probably has some of those issues about suicidality in part because of its very short half-life. The SNRIs, so serotonin norepinephrine reuptake inhibitors, these dual-action meds, are another large class of medicines. Venlafaxine was the first one available in the US, and it has some trials for use in depression, including, of course, the Tordia trial that I talked with you about, and some mixed data in those trials. There have also been a few small studies and case series using venlafaxine as a kind of down-the-line treatment for ADHD. And actually, Strattera is a selective norepinephrine uptake inhibitor, so it's got some similar action, and that one, of course, has the indication for ADHD. However, the challenge with venlafaxine is that it's been shown in some of these larger analyses and in post-marketing data to have a higher risk for suicidality than the SSRIs, and the company itself has put a label on it warning against the use in children and adolescents. Desvenlafaxine and duloxetine are the two other SNRIs that are available in the US. Desvenlafaxine is a synthetic version of an active metabolite of venlafaxine, and then duloxetine is structurally different. Duloxetine, which is Cymbalta, is the med that's also been getting attention and has FDA approval in adults for some chronic pain problems like neuropathy, diabetic peripheral neuropathy, and fibromyalgia. Neither of these have much data in kids. It's really limited to case reports and case series. There are no large studies, no controlled studies that have been published, but people are looking at these for use in kids. Now, since this is evidence-based depression care, I haven't spent as much time here, but if you want a reference and a resource for dosing on these, I have this here for you. Venlafaxine comes in the short-acting and the long-acting form, the XR. And we usually, if we're going to use it in kids, often use the XR. Venlafaxine itself is very short-acting, and it's got a nasty withdrawal syndrome. Kids feel fluey, they get zingers up and down. It can be kind of nasty, so we like to use the XR if we're going to use it. few other medications that you'll probably hear about and encounter that I've kind of briefly summarized here. Bupropion, Wellbutrin, has indications in adults for depression and smoking cessation. It also has had some study in ADHD in kids, and this is a norepinephrine and dopamine reuptake inhibitor. We use this sometimes. Bupropion can be a little bit more activating, and so for some kids who are really down and having that kind of behaviorally inhibited form of depression, sometimes it can be helpful. Mirtazapine, Remeron, it has indications for depression in adults, sedating, and also increases appetite because of histaminergic effect. So sometimes we use this in our chronically ill kids, especially in the oncology population. Trazodone is one of the older antidepressants. It's quite sedating, so most people actually can't tolerate it in antidepressant doses because they'll sleep all day long, but people use it as an off-label treatment for sleep, and it can be helpful for certain kids for depression. One of the things you have to worry about with trazodone in boys is priapism. And then the tricyclic antidepressants, the older antidepressants, actually do not have good data for use in kids. Several negative studies for depression in kids, and so these are not recommended as treatments for depression. But there have been positive studies for headaches and neuropathic pain, and they can be useful in that situation. So we'll talk briefly about suicidality. I think most of you have heard about the black box warning that came out in 2004 for suicidality in kids. Just a word about how they got there. What they did is they looked at published and unpublished data in multiple studies of antidepressants in kids, and they defined suicidal events. So this was thoughts, non-suicidal self-injurious behaviors like cutting, suicide attempts, etc. There were no completed studies in any of the data that they looked at, but these groups were equally depressed and generally equal in other regards. About 4% of the kids in the medication group had suicidality versus 2% in the placebo group. So there did seem to be a real effect. The highest risk seemed to be in the first couple of weeks, and this led to the black box warning. Now, this is something that's important to talk about with families, and again, we talk about some of those warning signs like the restlessness, the hopelessness, those kinds of things. But I would encourage you not to see this as a reason not to prescribe. You probably have heard about the data about trends for completed suicide. Suicides in this adolescent group were going down for years and years until 2004. And in 2004, when the black box warning came out, we had a bump in suicidal ideation, or completed suicide in both boys and then especially in girls. It's not a smoking gun. There may be other things that could have been related to this, but there are concerns that maybe the pendulum swung too far. And clearly untreated depression is a major risk factor for suicide in kids. We want to make sure they get treated. A study I find helpful in talking with families especially, and also in reassuring myself, is this pooled data of 13 trials, so almost 3,000 kids. And the take home with this is the number needed to treat to help kids with depression was 10. The number needed to harm with suicidality was 112. So again, this is a risk-benefit discussion that you have with kids and families, but these are safe and effective treatments. Now I'll move on to therapies and give you a little bit of a sense of what happens if you can get your patients there. And again, this is a nice non-suicide inducing treatment. Cognitive behavioral therapy is a therapy that is one of our structured evidence-based treatments. It tends to be 12 to 20 sessions, typically occurring weekly, and then after a child finishes an acute course, they may come back for a couple of booster sessions. The C part of CBT is cognitive, so we look at automatic negative thoughts that kids are having, like if they walk into a classroom and everybody becomes quiet, a depressed kid might think they were talking about me, they were saying bad things, I'm a horrible person, nobody likes me, where another kid might say, oh, maybe the teacher just said, we're going to start class. We have them start to recognize the connection then between their thoughts and their emotions. Behavior, what we see with kids who are depressed is that they tend to slip into being more and more behaviorally withdrawn. Once you're not going to school, once you're not participating in sports, once you're not hanging out with your friends, that alone can cause mood changes, and it becomes harder to do those things again. Once you're out of the loop, to get back into it is more difficult, and so it tends to perpetuate depressive symptoms. So in CBT, we try to help kids both do some behavioral activation, start engaging in pleasurable activities, start getting back into life. And we also help them recognize some of the thoughts that they have that lead to depressive cognitions. There's good evidence for a variety of formats for this. It's been delivered in school-based groups. It's been delivered, obviously one-to-one was the original way. We have family-based CBT where kids and parents meet together and learn these skills, or separately. They've had some data out of Canada about computerized CBT. There's several different formats for which CBT can be helpful. IPT is our other main evidence-based psychotherapy. This is a little bit less structured therapy, but remains kind of a brief problem-focused therapy, again 12 to 20 sessions, and focusing on interpersonal areas. The basic conceptual idea with IPT is that depression affects your relationships and relationships affect your mood. And in IPT, a child and therapist will talk about these 5 interpersonal areas: grief, role disputes, role transitions, interpersonal deficits, so social skills problems, and single-parent families. Initially in IPT, we spend a lot of time in psychoeducation about depression. Again, when kids are crabby and difficult to be around, there tends to be a breakdown in the relationship with their parents because they can get blamed for what's going on. So we spend a lot of time talking about how this is related to the child's illness, this illness called depression. It removes blame from the child, and we sort of say they're sick right now. They may not be able to do all the things they used to do, and we're going to work toward that. And then the child and the therapist work together on identifying 1 or 2 of these areas that they want to work on together. They'll do things like problem solving, talking through things. They'll do role play of difficult interpersonal situations. They'll work on some of the situations going on in the family. Some of these models that I talked to you about with depression care in the medical home. Now, our classic model is this referral model. You see a child, you call up your local psychiatrist, or you tell the parents you need to get to see a mental health provider. And when you have people who are accessible to you, people that you've built relationships with, people you communicate well with back and forth, this can be a good model. And in places where access is available, in communities and populations where it's available, this can be a very helpful way of getting kids care. But in a lot of pediatrics practices, for a lot of our kids, they're not able to access that care like we talked about at the beginning. Some ways of getting around this: there have been the co-location models. So this is having sometimes a psychiatrist, often a social worker, come into your practice and be there for a certain period of time during the day, be contracted to see kids in the office. This can address some of the access issues. It also addresses some of the stigma. They don't have to go to a shrink's office. They're just coming to their pediatrician. And they're seeing somebody in your office. It's somebody who's part of, in the patient's mind, part of your staff. It's part of going to see their doctor. And it can make depression, really, in these patients' minds, too, a medical issue that's addressed in the medical home. These enhanced care models are some of these new models, mostly grant-funded, where they've taken nurse or social work care managers who do phone check-ins with the patients. They use rating scales. They do other things with patient and parent to try to enhance the care that you provide. So some of these models, it's the care manager who's taking all these rating scales, following the patient, and then every few weeks they sit down with their pediatrician. And then these access lines, which are available in several states, where pediatricians call up a psychiatrist and are able to get questions answered over the phone. I'm going to spend just a couple of minutes. I listed some 10-minute therapy appointments, some things you can do in your office for kids who can't make it to mental health in the context of a med check. Some of these ideas. One is to take that IPT idea to talk about depression in a medical model, to talk about it as a chronic illness, the same way we often use the image of diabetes, where this is an illness that's definitely got a medical basis, and there are things that you need to do with your pediatrician, with your doctor, with sometimes an educator to get your diabetes better. But there's things you can do on your own, like following your diet and exercising and taking your insulin and doing those things to help your diabetes be better. And we'll talk to kids about how depression is similar, that there's many things you can do on your own, but you also need to work with your doctor on it. Mood monitoring, so having kids take a mood log and start to notice when their mood feels down and see if they can identify some of the situations and thoughts and feelings that went along with that mood change, and then have them come back at their next med appointment and review that with you. This is a way of helping them be more aware of those automatic thoughts. Behavioral activation, so setting 1 or 2 positive goals for self-care or fun appointments. and follow up with them on kind of holding them accountable to that at the next appointment. And then relaxation training, so working with them on taking yoga breaths, deep breath in through the nose, slow, deep breath out through the nose, slow, or progressive muscle relaxation, where they clench and release muscles either from head to toe or from toe to head, as a way of helping themselves calm down and get into sleep. I put some links on here for resources for your practice. Teen Screen has some screening tools. The AAP site has some great resources for you that you can use in your practice, and also some of the ongoing models for integration. NAMI is a wonderful resource for your families, and they've got like a 30-page family guide on depression in adolescents that provides really good information. And then the National Suicide Prevention Lifeline is a crisis hotline that you can give to your depressed kids and families. Locally, it connects with our local crisis centers, so they can both counsel in the midst of a crisis and provide referral services to local providers. And that's it.